Good morning, everybody. I am Dr. Sudhesh Phanse, consultant surgical oncologist at Raheja Fortis Hospital, Mahi. I've been working here for the last 25 years, and my specialty is surgical oncology. So I've been treating cancer patients, for the last 25 years. The topic for today is on postmenopausal breast cancer. Uh, Menopause is an event in a woman's life which there's no fixed date or time, but occurs anywhere from 45, 48, 45, 46 to around age 55. It's a gradual process, and it manifests you by cessation of menstruation. It heralds a reduction of ovarian function and a reduction in the sex hormones, estrogen and progesterone in a woman's body. It also signifies it also leads to postmenopausal symptoms like hot flushes and predominantly hot flushes. Ladies tend to put on some weight postmenopausal in a postmenopausal phase, but that's physiology. But what happens when patients suffer from breast cancer in the postmenopausal phase is it opens up another mode of treatment, and that is essentially hormonal treatment, and that's why I have chosen the topic today. We have the option of hormonal treatment for postmenopausal breast cancer patients. Now, breast cancer cells express what are known as estrogen receptors and progesterone receptors on their cell membrane, the breast cancer cells. And if this cell, if and the estrogen, which is one of the fueling factors for breast cancer, acts through this pathway, it binds to the cell membrane, the estrogen receptor on the cell membrane, and triggers off the process of carcinogenesis. So, breast cancer, as you realize, is a hormone dependent cancer. It depends on the levels of estrogen in the body. That is not the only factor. There are many other factors, but hormonal factors are one of the factors. So, if we are able to block the receptor and you block the estrogen acting on the cell, you are able on the cancer cell, you are able to control its growth, and over a period of time the cancer cell dies because it is deprived of the fuel or the estrogen required to keep it alive. Now you may ask me why this option is not available in the premenopausal phase, because cancer cells in the premenopausal phase will also have estrogen receptors. Yes, that is true. The issue is, in the premenopausal phase you have the ovarian function going on normally. The ovaries are secreting their normal to levels of estrogen, and it leads to a lot of competition between the drug that blocks the estrogen receptor and the estrogen itself, and hence it doesn't become an option of treatment. If you want to treat premenopausal ladies with estrogen and hormone blocking therapy, you have to do two things. You have to block the action of the ovaries, and that can be done by either removing the ovaries surgically, or then you have injections of hormones which block the secretion of estrogen. Now, the beauty of hormonal treatment is that it is very simple, without much side effect. It involves taking a tablet once a day or twice a day, with relatively less side effects, though there can be long-term side effects of estrogen treatment, but they can be controlled. So it's relatively simple, relatively easy, does not require any admission. It is also cheap. For example, tamoxifen tablets, the monthly course can be at around 150 rupees. So, most of the population can take this tablet, and that's why I wish to say that you keep this option in mind. As far as presentation of breast cancer, how will breast cancer manifest? Is like any other, whether you're premenopausal or postmenopausal, the manifestation remains the same, and that is either a lump in the breast. Now, it's a painless lump to begin with, and so it manifests as a lump in the breast. And there's another small advice to the ladies who are postmenopausal. The commonest cause of a lump in a postmenopausal lady is breast cancer. So if a postmenopausal lady has a lump in the breast, please don't ignore it. It is bound, the possibility of it being a cancerous growth is much more than of it being a benign growth. The benign tumors in the breast, like fibroadenomas and as such mainly, tend to happen in the premenopausal phase. So postmenopausal, if there is a lump in the breast, the possibility is that it is most likely to be a breast cancer. And hence my advice to all ladies is, please do not ignore even a small lump in the breast. Get yourself investigated and show it to your doctor. The other symptom could be a nipple discharge, especially a bloody nipple discharge. So be careful. If you have a bloody nipple, blood coming out from your nipple, please report it to your doctor. Get yourself checked. If there is a distortion of your nipple, okay, because that represents a tumor growing just below the nipple, and that can lead to distortion of the size or shape of the nipple. If that happens, or indrawing or a puckering of the nipple, if that happens, please show it to your doctor. And then the third manifestation could be dimpling of the skin over the breast, or a distortion in the skin over the breast, if that happens. So these are the three main manifestations of post-menopausal breast cancers. And if one has this, please do not ignore this signs, and please report to your doctor or get yourself examined by an oncologist. That will probably help you in detecting cancer early. Now, what are the investigations generally ordered? Is most of the common investigation ordered is an imaging, and imaging for the breast can either be done by an ultrasound of the breast or by a mammography. There are more advanced imaging like MRI of the breast or a PET scan, but that can be for borderline cases, or for you want to do some special surgical procedures. You may need those investigations, but as a routine, and if you ask me, in my opinion, an ultrasound of the breast or a mammography of the breast is good enough. It gives you a lot of information. It tends to predict the type of a tumor, whether it is benign or cancerous. It also gives you the size of the tumor, whether it's a T1 lesion or a T2 lesion. Now, lesions or tumors less than 2 centimeters in size are considered as T1 lesions for breast cancer, and tumors between 2 centimeters to 5 centimeters are considered as T2 lesions of breast cancer. These are important because it helps us in deciding the type of treatments that can be offered to patients with breast cancer. A small word on screening for breast cancer. The commonest question is, and we do have a screening modality in terms of mammography. Mammography is nothing but an X-ray of the breast, and you can pick up a tumor of the breast in the breast by certain specific characters which are identified on the mammography, and one looks for tumors in the breast. Now, for a tumor to be palpable or felt in the breast, the tumor size has to be a minimum of 1.5 centimeters in expert hands. So an average lady or a common lady would pick up a tumor in the breast by the time it is around 2 centimeters in size, so that becomes a T1 tumor. Almost sometimes, very often, it's a T2 tumor because they are around 2.5 centimeters in size. If you want to pick up a tumor before that, less than 2 centimeters, then you have to use either mammography or ultrasound. So these imaging modalities are useful in picking up tumors before they become palpable. Now, who should be doing screening? What is recommended is after the age of 50, once every 3 to 4 years, you get yourself examined. Please don't do it more often, that's not required. What the recommendations are 3 years. So every 3 to 4 years, you can get yourself examined for breast cancer. I would recommend this more for patients who are at high risk. Now, what is the high risk classification? If there has been a family history of breast cancer, either in your mother or your sister or your maternal aunt, that you could be classified as being in a slightly high risk. So these patients must definitely have their screening done. Treatment for breast cancer. Once you have a diagnosis, once you see a breast tumor, you obviously would do a biopsy. Biopsy can be a core biopsy or a FNAC that is done with the help of an ultrasound guidance, and it gives you the diagnosis of a breast cancer. So once we have a diagnosis of breast cancer, one does what is known as a metastatic workup. We want to find out whether the breast cancer is limited to the breast or it has gone to other organs. So that is essential for planning the treatment. So you then need to do what is known as a PET scan. If PET scans are not available, you can do investigations like what we did before PET scans were available, and they can be either they are simple investigations like chest X-ray, ultrasound, and if you still have some symptoms of body ache or backache or things like that, you could do a radionuclear bone scan to rule out bone metastasis. So if there is no evidence of any spread in these organs, one then says that classifies the patient as localized breast cancer, that is tumor localized to the breast, and we then treat the patient accordingly. So if your tumor size is less than around 4 centimeters, that is or up to 5 centimeters, up to T1, T2, these are further classified as early breast cancers. So early breast cancers are treated primarily with surgery first, followed by other treatment options, namely hormonal treatment and chemotherapy and radiation therapy. So if you have early breast cancer, you would be recommended to undergo surgery. Surgery can again be of two types. If your tumors are around 2.5 centimeters, you can be offered, or you can do what is known as conservative breast surgery. What is the meaning of conservative breast surgery? Is you don't need to have a complete removal of the breast. The operation which is known as a mastectomy, so that need not be done, but you can have what is known as a lumpectomy or removal of the lump and the lymph nodes in the axilla. But if you opt for conservative breast surgery, then radiation to the breast is mandatory. You have no option but to undergo radiation to the breast. Radiation treatments last for around 6 weeks, so you have to add one more modality of treatment for breast cancer. If you opt for a mastectomy, then post-mastectomy, if you have a very high number of nodal metastases, that is more than 3 nodes are showing presence of metastases in the axillary nodes, which are removed at the time of surgery, then you would be recommended to undergo radiation also. But generally, the incidence of metastases with T1, T2 tumors is less than 20% or 25%, and they're less likely to be more than 3. So most of the patients with early breast cancer, if your, if your preoperative imaging modalities have shown no metastasis in the axilla, generally surgery is adequate. Once surgery is done, then patients are put on adjuvant treatments. Adjuvant treatments are, what is the rationale of adjuvant treatment? Adjuvant treatment means treatment added to surgery. You treatment more than surgery. What is the rationale for treatment more than surgery? Is you are now trying to treat microscopic disease which might have spread to the rest of the body. That possibility always exists. And here we have many options. Again, mainly hormonal treatment. As I had explained in the post-menopausal phase, the hormonal treatment is a very good option. So you have hormonal treatments and then you have chemotherapy. So of the specimen that is removed or the tumor that is removed, further receptor studies are done. It tells us whether the 3 commonly done receptor studies are the estrogen receptor, the progesterone receptor and the Herceptin receptor. Okay. The Herceptin receptor is another type of receptor for another pathway, and you have drugs available to block that receptor, which is different from the standard or the classical chemotherapy. So the Herceptin receptor, if your tumor is Herceptin positive, then taking anti-HER2 treatments does improve survival and is recommended in the present state. The form of treating, modality of treating HER2 positive patients is to use a drug called as trastuzumab, or which is then given for 12 to 18 months on a monthly basis, along with your other treatment, which is either hormonal treatment or chemotherapy. So if once you have had a surgery, you are either ERPR positive or ERPR negative. If you are ERPR positive, then and 60 to 65% of patients in the post-menopausal phase are ERPR positive. So that opens up, as I had said, the whole option of treating 60 to 65% of patients with hormonal treatments. And if you don't have a very advanced disease, like say your lymph nodes are negative, or you have just one lymph node positive, and you are strongly positive on the ERPR receptor, then hormonal treatment becomes adequate. So post-menopausal patients, early breast cancer, strongly ERPR positive, these patients can be just treated with hormonal treatment. So you have a mastectomy, if you opted for one, you have a mastectomy, and then you go on tablets. So the whole treatment becomes very simple, one surgery, and after that just tablets for 5 to 7 years. It is like taking a tablet either for blood pressure or hypertension and things like that. So these patients, the treatment options for these patients becomes very simple, and a lot of these patients go on to live for long time. 5-year survivals for stage 2 breast cancer is close to around 75%, 7 to 8. So 8 out of 10 patients will probably be cured of their disease, and they lead a normal life, a healthy life, and they go on to do whatever they can, whatever they want to do. If you are ERPR negative, then we have no choice but to then recommend chemotherapy. So there is a standard chemotherapy which is given. The chemotherapy treatments last for around 6 to 8 months. Around 6 months, the standard chemotherapy treatments last for 6 months. If on top of that, if you are HER2 positive, then the anti-Herceptin treatment will last for a year and a half. Chemotherapy has improved vastly. The common thing that people had about chemotherapy is about the side effects. So modern chemotherapy drugs, the supportive treatment has improved dramatically over the last 2 decades, and the side effects are much less. Patients come in the morning and they go take the chemotherapy, and they are home in the evening. So most of these patients take chemotherapy on a daycare basis. Side effects last for 2 to 3 days, after which the effects go down and patients can lead a normal life with little precaution. So I've had patients who have come on a Friday and they have had Saturday, Sunday at home. Monday onwards they've carried on with their normal routine, especially some of the working ladies. I'm also talking now of premenopausal ladies who need chemotherapy. A lot of them are working ladies, and they don't want to miss their office and work. Some of them have been, a lot of them nowadays are in very important managerial positions, shouldering major responsibilities in their organization. So they come on a Friday or a Friday afternoon or a Friday, take their chemotherapy. Saturday, Sunday rest at home. Monday they are back to work. So the scenario for chemotherapy has changed dramatically, and we now have multiple drugs available. So what chemotherapy has done is it has kept patients alive for a longer time, and I can say that not in the situation of early breast cancer, but I'm talking of a situation of metastatic breast cancer. What is the situation? It is like if you develop metastasis, or if you present with metastasis with breast cancer today, do we say it is the end of the road? I said no. You can have meaningful life for a long time. I have had patients with metastatic breast cancer in the post-menopausal setting. They have a breast lump, and when we do their imaging, it reveals multiple metastases to the bone. You see, so this becomes a metastatic breast cancer, and they have these. Fortunately, these tumors turn out to be strongly ER/PR positive, and these patients have been kept just on hormonal treatment. You just give them hormonal treatments, and the tumor responds, and they have gone on. A couple of my patients are alive 4 years after into their 4th year of treatment. Sometimes we need to change the drugs depending on the responses, but patients are living a healthy, a normal life, carrying out their whole activity. So my message to all the patients with post-menopausal breast cancer: don't fear the disease. Come forward. Take your treatments. Multiple treatment options are available today. Treatments are kinder. We don't have much side effects, and if there are side effects, we can take care of them. Radiation modalities have improved dramatically over the last 10 to 15 years. The new machines, the side effects of the new machines is much less than what we used to see 20 years ago. The treatment options are there. So I would just end by saying lot of hope for patients with post-menopausal breast cancer. Lot of treatment options available. Cure rates are extremely high, especially if you come early. Even in the metastatic settings, patients live for many years, as we have multiple drugs to treat breast cancer now. So I would say, don't fear the disease. Come forward, take your treatments, and lead meaningful life. A small word on the post-COVID situation. We have seen the epidemic is definitely waning. That's good news for all of us. The number of admissions in the hospital, COVID-related admissions in the hospital, are dramatically down. We now, from a situation where we used to have around 120 COVID patients, we are now down to less than 10 COVID patients in the hospital. The routine work has started. The routine work is picking up. So I would recommend all patients, if you develop cancer, you need treatments, please don't hesitate. Please come forward, and let's start your treatments, and let's get going with your treatments. So if there are any questions, I can take it.